All right. You guys ready to get started? All right, yeah. All right. So, it is my understanding that over the course of the last 4 lecture periods, you guys have had exposure to basic concepts as it relates to antimicrobial pharmacology, right? Okay. So, what I'm going to try to do today is take all of that information that you just learned and try to put it into a context maybe that can help you understand how clinical decisions are made, and maybe, if nothing else, understand how I make clinical decisions, the criteria that I use. This is a quote from the French philosopher Voltaire. Doctors put drugs of which they know little into our bodies of which they know less to treat diseases of which they know nothing at all. My guess is that at this point in your veterinary career, you'd probably flip this quote around a little bit and say that we probably have a reasonable understanding of disease, we have a good understanding of the body, anatomy and physiology, but it's the drugs of which we know absolutely nothing at all. It's difficult to make those connections, right? How do we take what we're learning in pharmacology, PK, PD, ADME, and put that into something that you can understand to make clinical decisions that affect the outcome of a patient that you work with. So we're going to start off with some general considerations that I have when I'm making decisions on antimicrobial use. When to use it and what to use. How do I get to that point with all that crap that you've just had stuff into your minds? We'll talk about what it means for the real world. All this theoretical mumbo jumbo, how do you put it into the realm of clinical practice? We'll talk about busting myths as it relates to antimicrobial use. There are some things that you've been taught that are just dogma, probably not right. And then take home points, and I'll take any questions that you guys might have. But is this sort of how you feel right now? Yeah, I mean, and not just this, right? But this generally speaking, is probably how you feel in general. But when you look at pharmacology and antimicrobials, you've had all this information dumped at you, and this is how it feels. And when we talk about antimicrobials, we're talking about spectrums and susceptibilities. Are they synergistic or antagonistic? Do we have sidal? Do we have static? Root and frequency toxicities? How do we make sense of all of that information? Okay? So what we're going to do today is we're going to try to put it all together into a context that maybe makes a little bit more sense to you. So there are 10 questions that I ask myself when I'm working with a clinical patient and trying to make a decision on do I need an antimicrobial and which one am I going to use. The first question is an antimicrobial required? And of these 10 questions, that is the one that is most important. Okay? I have tried over the last 13 years to understand the various factors that relate to emergence of resistance in large animal pathogens. And what I have come down to in that 13-year period, sidal or static doesn't matter. Broad versus narrow doesn't matter. The most important question you can ask yourself is, do I need it or do I not? Yes or no. That is the biggest driver when it comes to resistance, is using antimicrobials inappropriately. We'll talk more about that a little bit later. But if the answer to that first question is yes, the next thing that I need to have some understanding of is what is the identity of that infecting pathogen, okay? The reason for that is, and again, we'll talk more about that in just a second, is I can't wait 6 days, 7 days for something to come back from the diagnostic lab. I've got to treat that animal empirically in most cases. Lump samples that I submitted to the diagnostic lab last Friday morning just came back 10 minutes ago. 6 days. If I'm dealing with an outbreak, I can't wait for those samples to come back to help me know what I need to use. I've got to have some empiric idea of what's there. Once I know what the pathogen is, I need to have some understanding of what we're working at test tube. So I can start to put together what would be reasonable choices and what would not be reasonable choices. From there, I've got to start to think about the nature inside of the disease process. In a test tube, everything is perfect. pH is neutral. I don't have to worry about tissue debris. Oxygen tensions are set at a certain level. Infections don't work that way. Okay? I need to know if the antimicrobial will be effective in the local environment. I need to know what drug dosing regimen should I be using. How safe is that drug? Are there legal considerations related to antimicrobial use? What is the cost of therapy? And then how long should I treat? So those are the 10 questions that I ask myself. And every time I'm working with a clinical patient and I'm deciding antimicrobial, yes or no, I go through this decision tree every time. So, first question, is an antimicrobial required? The use of an antimicrobial is not innocuous. Keep in mind that these compounds are chemical toxins that should be selectively toxic to microorganisms. But there are some that we use that have toxicities that can have significant impact on the mammalian body, impact outcome, survival for that matter. So using an antimicrobial for a minor infection that would be better treated locally or maybe just left alone to granulate in and heal on its own. Using an antimicrobial for a viral infection or an inflammatory disorder. An example of that would be recurrent airway obstruction or asthma in horses. That's entirely inflammatory and doesn't require antimicrobials. We could induce disease with those antimicrobials. Colitis in horses, renal failure, ototoxicity with aminoglycosides. Other than that, we might see issues with antimicrobial resistance, pathogens that could potentially infect that patient later on, or pathogens that in food animals could spill over into humans because they consumed a tainted food product. So keep in mind that this is not an innocuous thing, and there are consequences to it that we've got to think about. So you're presented with this case. It is a 9-day-old Simmental bull calf. And he's got a couple-day history of diarrhea. In your physical exam, he's bright, alert, responsive, nursing vigorously. Temperature is 101.5, heart rate is 88, respiratory rate is 32. You notice fecal staining on the perineum and hind limbs. Mucous membranes are pink and moist, but otherwise this calf is normal. Is an antimicrobial required in this patient? No, it's not. But if you look at surveys of cattle producers, you look at surveys of veterinarians, a majority of them would treat this calf with an antimicrobial. And if you look at studies where they've gone in and implemented a decision tree-based algorithm for the use of antimicrobials, we can cut antimicrobial use by 90% on farms without any untoward effects on the health of the patients that we're dealing with. So this is a patient that, as much as anything else, maybe needs fluids. My rule of thumb with a beef calf is if I can't catch it, I don't need to treat it. But this is a calf that otherwise doesn't need one. But like I said before, a lot of producers and a lot of veterinarians would give this calf an antimicrobial. It doesn't need it. Next, if the answer to that first question is yes, I move on. What is the identity of the infecting pathogen? Okay? So I need to understand what spectrum I need to optimize therapeutic outcome. Do I have the right or the wrong spectrum? Is it within the spectrum or is it outside? Like I said earlier, my initial therapy is often going to be empiric. Even if I submit samples, there's a delay in getting the results of those samples back. I can't wait 6 days with an animal that needs an antimicrobial to start something. I have to start it today. So it could be the clinical presentation, maybe it's the patient history. I've got some understanding of disease pathophysiology that gives me some sense of this is what I think is probably here. And if we look at horses and bacteria that are commonly isolated from different body sites in horses, if we look at the trachea of horses with bronchopneumonia, the most common isolates that I identify is strep zoe. Without question, strep zoe. Now, I could also see actinobacillus, some pasteurellas, and a smaller proportion of E. coli's. But when I diagnose an adult horse with bronchopneumonia, strep zoe is the pathogen that I'm most concerned about. So my empiric therapy would be targeted against strep zoe. So with that in mind, what would be an appropriate empiric therapy for a horse with pneumonia caused by strep zoe? What's that? Penicillin. Strep zoe is exquisitely sensitive to penicillin. We have seen no resistance emerge over the course of time to that drug. So penicillin would be a very, very reasonable choice. Let's say I've got a weanling foal. Not really very well halter broken. Maybe I can handle it, but penicillin I've got to give daily, and I'm getting very large volumes of penicillin to that foal daily. What would be another reasonable choice for that foal, convenience being factored into it? Ceftiofur. One formulation of ceftiofur specifically, Exceed. Single injection, 4 days of coverage. So automatically I know where the spectrum goes. If I look at the uterus, same thing, strep zoe. But I've also now got a higher proportion of E. coli's and some staph that I've got to deal with too. And if I look at the eye of a horse with infectious keratitis, oh my gosh, strep zoe. But I also have to think about staph and other streps too. But automatically, when I make a diagnosis, I know where my spectrum needs to go. Strep-zo has got to predominate, but if I'm looking at the uterus, I've got to start thinking about E. coli. So I'm looking at the eye, staphs have to come into consideration for me too. If I look at bacteria that are isolated from beef steers with BRD, and this comes from a survey of 4 Canadian feedlots, okay? It differs a little bit by feedlot, but what you'll notice is that it's going to be Mannheimia, Pastorella, or Histophilus, one of those 3 pathogens. So if I'm looking to deal with respiratory disease in a steer in a feed yard, I'm covering non-enteric gram-negative pathogens like Mannheimia, Pastorella, or Histophilus. Spectrum-wise, penicillin, ampicillin, probably not the best choices. They don't cover those pathogens very, very well. Fluoroquinolone, ceftiofur, a macrolide, potentially be very, very reasonable choices, everything else being held the same. But just knowing what's there helps me understand what would be a good empiric choice. If we look at dairy calves, though, if we look at the bacterial pathogens in dairy calves, Mannheimia and Pastorella tend to predominate. The other thing that you notice is mycoplasma can be found in about 50% of those samples. And if mycoplasma is a significant contributor to respiratory disease in dairy calves, what one class of drugs would I not want to use? So what is unique about mycoplasma when you compare it to other bacteria? They lack a cell wall. So what class of antimicrobials targets the bacterial cell wall? The beta-lactams. So if mycoplasma is a significant player in BRD in dairy calves, beta-lactams are off the table automatically. Not the best choice for me. Despite the fact they might cover these, ceftiofur particularly, if this is a concern for me and I think it's significant, they're not an option. I've got to go with drugs that have activity against mycoplasma. Okay. Next, once I understand what I think might be there, and in my mind I'm starting to organizing what could and what wouldn't work, just based off what I know that organism could be susceptible to, I need to know what in vitro works against those organisms. In vitro susceptibility testing, neutral pH, no debris, and an aerobic environment. That does not hold true at most sites of infections. They're either going to be acidic generally, they could be basic. A lot of them are going to have lower oxygen tensions, and we're going to have cellular debris that we've got to counteract. Okay? But at least this gives me a place to start. If we look at susceptibility of BRD pathogens to oxytetracycline, and we look at Mannheimia in the purple, Pastorella in the gray, Histophilus in the black, over the course of time from 2008 to 2016, the proportions of Mannheimia that are resistant to oxytetracycline ranges from 60 up to about 85%. So despite the fact that oxytetracycline is technically within the spectrum for Mannheimia, resistance patterns that we've seen over the course of time looking at cumulative antibiograms would suggest that it's really not the most appropriate drug for me. Okay? If we look at Mannheimia, susceptibility to other drugs over the course of time, and we look at ceftiofur, enrofloxacin, fluorophenols, spectinomycin, tilmycin, and tetracycline, ceftiofur, over the course of a 9-year period from 1994 to 2002, 96 to 100% of susceptible. Enrofloxacin, we've got 4 years, 89 to 98, fluorophenols, anywhere from 87 up to 100. Those would all be very reasonable choices. But if I look at spectinomycin, tilmycin, or oxytetracycline, I start to sacrifice activity. Even though theoretically they're within the spectrum, resistance has begun to emerge. So for me, based on this data, I'm dealing with a beef calf with BRD. I'm going to go to one of these 3 drugs, everything else being held the same, over these 3 drugs because resistance is so common to them and they might impact the outcome of therapy. Does that sort of make sense? Okay. Next, what is the nature and site of the disease process? So we're trying to take the in vitro results and correlate them now to what's going on inside that animal. All right. Does that drug have to cross a barrier? Do I have an infection in the mammary gland? Do I have something that needs to get into the blood-brain barrier, foal with meningitis? Despite the fact that something might work in a test tube, now I've got to figure out how it can get to that site. Right? Is the infection sequestered somewhere? So I'm dealing with septic arthritis, osteomyelitis, or a foal with rhodococcus. This is fluorphenicol. This is gomithramycin, which is a 15-membered macrolide, very, very chemically similar to azithromycin. These are the concentrations of each of these drugs in synovial fluid of healthy cattle. Okay? One of the most common pathogens we see in cattle with septic arthritis is Trupperella pogenes. Okay? And the assumption that we're going to make is that both gomithramycin and fluorphenicol are equally active against Trupperella in vitro. If I put them in a test tube, the MIC that I get back is going to be the same, and it's going to be 0.25 micrograms per milliliter. So in other words, I have to achieve a concentration of 0.25 mics per mil in some tissue matrix, in this case joint fluid, with both of those drugs to slow the growth of that pathogen. Sort of make sense? Okay. So in vitro, they're the same. So theoretically, they'd be reasonable choices either way. But this is fluorphenicol. Notice that I'm above the MIC with a single dose of 40 mg per kg for 6 days. With gomithramycin, despite the fact that it works in a test tube, here's the target concentration, here are the levels of gomithramycin. I don't get there. It works in a test tube, but I can't get it to the site of infection. It doesn't accumulate synovial fluid. That sort of makes sense? Okay. So when I'm dealing with septic arthritis in cattle, just because of the fact that it concentrates in synovial fluid to such a high extent, that is my first choice. And the nice thing about it is a single dose at 40 mg per kg, 6 days of coverage. I can dose it almost weekly if that assumption holds true. Okay? Now, this is looking at concentrations of ceftiofur in placental tissues of the horse. And we've diagnosed a mare with placentitis. The most common cause of placentitis in mares is what organism? Take a wild guess. Strep zoo. It's a horse, strep zoo. It's like a cow with BRD. It's Mannheimia. The most common cause of placentitis in horses is strep zoo. In vitro, ceftiofur is really active against strep zoo. It would be a great empiric choice, okay? But remember, I'm not targeting plasma. I'm not targeting the lungs. I'm targeting the placental tissues, in this case, the fetus. That's where my infection is. Okay. So if we look at concentrations of, in this case, a ceftiofur metabolite in colostrum, chorioallantoic tissues, the amnion or the umbilical cord, needing that target concentration to be 0.2 micrograms per mil or gram, depending on what matrix we're looking at. All right, if I had strep zoo in the mammary gland of that mare, ceftiofur in this case would be a reasonable choice. I can get there at relatively high levels. All right. But remember, I'm dealing with the placental tissues. My target is 0.2. With the chorioallantois, in whatever site you're looking at, the amnion, the umbilical cord, do I ever reach a concentration, bastard, do I ever reach a concentration of 0.2 at any point? You never get there. So despite the fact that ceftiofur in vitro would be a great choice, I can't get it there clinically. So I default to other choices. I go to Pingent. I go to TMS. They still work in vitro, maybe not as active as ceftiofur, but I can actually get them to the site of that infection. Okay? Does that sort of make sense? Okay. The next question is, will the antimicrobial be effective in the local environment? All right. So, like I said before, in vitro, perfect conditions. Aerobic, neutral pH, no debris. Here, we're getting to the site of infection, and I've got debris. I've got necrotic cells, dying bacteria, sloughed epithelial cells in some matrix. If I look at the sulfonamides, in the presence of cellular debris, the sulfonamides, because they antagonize the activity of folate in bacteria, can actually be overridden by the folate that accumulates from the necrotic cells in that debris. So despite the fact that that drug might work in vitro, when there is no excess folate there, in the presence of necrotic debris, the folate that's released from those dying cells overrides the ability of the sulfonamides to antagonize that. That sort of makes sense. Okay. Aminoglycosides are also highly bound by cellular debris. So in debris-ridden environments, as much as an aminoglycoside might look good on paper, they're not a great choice. The other thing is, aminoglycosides have no activity in anaerobic environments at all. They are poor choices for anaerobic infections because the activity of the aminoglycosides is dependent upon oxygen uptake inside the bacterial cell. Without oxygen, they can't be taken up inside the cell, and they can't exert their effect on the ribosome. So with acidic pHs and low oxygen tensions, aminoglycosides aren't a great choice. This is a study in ponies where they implanted tissue chambers under the skin. And in those tissue chambers, they inoculated them with strep zo. And that strep zo isolate was highly susceptible to both TMS and penicillin. Okay? What you notice is that by 30 days after inoculation, the group that was given TMS, they still have a relatively high level of bacteria in those tissue chambers. Compared to the penicillin group, within 15 days, there's no bacteria there at all. The other thing that you notice, in the group that was given TMS, all 8 of them, within 10 up to 42 days after they were implanted, they all abscessed out. In the penicillin group, only 1. So despite the fact that in vitro, those drugs work together, and despite the fact that the sulfonamides can get into that tissue quite well, actually, much better than penicillin in most cases, the debris that accumulated in that site prevented them from exerting their effect. Next, what drug formulation and dosing regimen should I use? Anytime I've got a labeled dosing regimen, that is very, very specific for a species, an organism, a disease condition. Anytime I deviate from that label, those assumptions might not be valid anymore. So I have to start thinking about patient variables. Am I looking at a neonate versus an adult? What impact is disease having on host physiology and drug metabolism? Most label claims we have on antimicrobials today, those studies are done in healthy animals. And if you look at dogs, for example, giving ampicillin to a dog that's healthy versus ampicillin to a dog with renal failure, the assumptions that we're making about efficacy are a lot different because of how renal failure impacts the elimination of ampicillin. And has there been a previous history of treatment? So this is looking at the plasma disposition of Exceed or a long-acting ceftiofur formulation in foals that are neonatal, less than 7 days of age, and in weanling foals that are between 2 and 4 months. Okay? In weanling foals, the drug is targeted specifically at pneumonia caused by strep zo. Right? And with that labeled dosing regimen, looking for active concentrations to be achieved in pulmonary epithelial lining fluid or plasma, I would be above the target concentration in PELF for 96 hours or in plasma for 7 days. So in these 2-month-old foals, I can give a single dose and have therapeutic concentrations in blood for 7 days or lung fluid for 4 days. Pretty convenient. Now, let's say that, well, gee whiz, if it works this well in a weanling foal, it's so convenient to dose, Q4 days, I should use this in foals that are less than a week old to deal with sepsis. Dosing is really, really convenient. It makes it easy to do for clients. Because, right, these assumptions should hold true. It's just a baby horse. They're all the same. That's not true. If you look at neonatal foals, again, less than a week of age, this is my target concentration, 2 micrograms per milliliter. I'm only above the MIC in this case for 24 hours, and I barely reach that target during the course of that dosing interval. So understanding that there are some differences that occur with age that impact the assumptions we can make about how doses are given. Make sense? Okay. Next, safety of the drug. Does the drug have some untoward side effect? And if it does have an untoward side effect, am I willing to accept that risk? I need to be able to communicate that to the owner. This is the best drug that I think we have. Here's the risk of using it. Okay? And if I do have a risk, what should I monitor? If I put a cat on enrofloxacin, what is the potential side effect of that? What's that? Blindness. It has toxicity related to the retina. If I give doxycycline to a cat, esophageal strictures. Now, doxycycline may be a very good choice for that cat. Aminoglycosides. What are the issues associated with using aminoglycosides? Renal failure. So if I have a foal present to me, septic, one of the best empiric combinations I have for septic foals, ampicillin and amikacin. It'll cover about 94% of the isolates I encounter. But if that foal presents to me with a creatinine of 5, is amikacin the best choice there? No. So I'm going to go to other choices. Ceftazidime, ceftiofur, something that's a little bit safer but still has the spectrum. If I gave azithromycin to a mature horse, what could happen? colitis. About half the mature horses you give azithromycin to will develop diarrhea. Half. And then oxytetracycline. So this is a photomicrograph of liver and kidney taken from a feedlot steer given oxytetracycline at a dose of 33 mg per kg to treat BRD. Label dose is 20 mg per kg. So we weren't really that high. You've got lipid accumulation in the hepatocytes, and you've got the formation of tubular casts and tubular necrosis in the kidneys of that steer. These animals are often dehydrated. So using that extra label dose of oxytetracycline precipitated multi-organ failure in this animal, and it died, potentially because of something we did. The reason I bring this up is one of the most common things we see people do to neonates, large animal neonates with contracted tendons, is they give them oxytetracycline. The idea is that the calcium chelating effects of these drugs relax those tendons and help them straighten out. Well, the doses we use are somewhere in the neighborhood of 60 to 70 milligrams per kilogram, which is 3 to 3.5 times the label dose. Well, neonates with contracted tendons really don't nurse that well. They haven't gotten enough colostrum. They can be azotemic. So the potential to precipitate something like this in our hands because of something we've done is real. Again, these are not innocuous. Next, are there any legal and regulatory considerations that I've got to think about? All right. Anytime we think about food animals, we've got to think about withdrawal times. Yes, ma'am.
So in that case, would you recommend like not giving oxytetracycline for contracted tendons, or just like monitoring blood work?
Yeah, so the question is, what would I do in that case? I have a foal or a calf that's presented to me with contracted tendons. What would I do? I'd splint it, I'd bandage it, maybe put cast, and use that to relax the tendons as opposed to using something that is, actually the evidence would say, at least in calves, it doesn't even work at all. If that doesn't work, then we cut the tendons and use that to address the problem. Okay. With food animals, we want to minimize the risk of violative residues popping up in some product that they're producing. The issues with that go back to allergic reactions in people that consume those products. Anybody here allergic to penicillin or anything like that? All right. So that's a real concern for a lot of you guys in this class. If you had a product that was tainted with a beta-lactam, that could be life-threatening to some of you. That's significant. That's a problem. Chronic toxicity or resistant pathogens being transmitted through the food supply. Today, Campylobacter and non-typhoidal salmonella are pathogens that have been documented to move from the food supply into people, and we precipitated resistance in those pathogens. It happens. It's real. So we've got to think about that. What we do with those withdrawal times is we establish a tolerance in edible tissues. So one of the things we've got to be honest about as an industry is help people understand that when we market a product and that animal is slaughtered, it's been treated and is past its withdrawal time. So Baytril, given to a cow for BRD, the withdrawal time is 28 days. So I've treated the animal, 28 days has passed, now it's marketed and slaughtered. We are not telling that consumer that there is no residue at all in the edible tissues. Typically it's muscle, kidney, and liver, which are the target tissues they test. It is below an established tolerance, which has been deemed to be safe for consumption over a lifetime. So if anybody asks you, are they free of antibiotics entirely? If they've been treated, there's no guarantee. Oxytetracycline, for example, if you actually sample pigs that have been given CTC or chlortetracycline in feed, you can find CTC in the bone of those animals for over 2,000 days. But it's below a tolerance that's been established. So we've got to be honest with the public about that and help them understand that it ain't free, it's just safe. With food-producing animals, you have major species, which are cattle, swine, and poultry. Those are the three major species. Everything else are minor species: cervids, game birds, small ruminants, rabbits, and wild bear. Horses and camelids are companions and are very similar to what we see with cats and dogs. They do not fall under the withdrawal times established for the food-producing animals. Now, sheep and goats are often kept as pets, goats particularly. I have 2 useless pet goats. And most people look at goats and say, oh my God, that's cute. Right? That's cute. The FDA looks at that goat, and this is what they say. Right or wrong, from a regulatory standpoint, this is a food animal. And the restrictions that apply, with some exceptions, to cattle apply to these animals as well. So that's something you've got to think about, okay? Whether that goat sleeps in the bed with the owner or not, that happens. I've seen pigs do it too. Whether they sleep in the bed with that owner or not, that pot-bellied pig, which is considered to be a part of the family, is a food animal. It is just the same as a production pig. You got to think about that, and the restrictions apply. So, with food-producing animals, we have Group 1 drugs, which have no allowable extra-label use. That would be chloramphenicol, the fluoroquinolones, glycopeptides, medicated feeds, and the nitroimidazoles. All right, so chloramphenicol. There are no labeled indications for the use of chloramphenikols in food animals. Do you guys know why? Chloramphenicol is associated with fatal aplastic anemia in 1 in 40 to 60,000 sensitive individuals. Okay? Fluoroquinolones, the two that we use in food animals today, enrofloxacin and danofloxacin, are labeled specifically for respiratory disease in cattle and colibacillosis in pigs. Outside of those label indications, no. Okay? The glycopeptides, vancomycin. Medicated feeds. We use a lot of medicated feed articles in food animals, but we cannot use them extra labeling. And then the nitroimidazoles, so metronidazole, ronidazole, other members of that class, cannot be used in an extra label fashion because they have no labeled indications or illegal. There are drugs with restricted extra label drug use. So with the cephalosporins in major food producing species, so this does not apply to sheep and goats. In a sheep or a goat, I can take ceftiofur and squirt it down their back if I thought it was reasonable. No restriction on that. But in cattle, swine, and poultry, I have to abide by the dose, route, and duration of therapy. I cannot deviate from that. And then sulfonamide in lactating dairy cattle. I cannot use sulfonamides in dairy cattle that are older than 20 months of age. Okay? How many of you guys have been over to the teaching hospital and seen our two blood donors? Buttercup and Brussels. You got to see Buttercup and Brussels sprout at some point. Physical diagnosis, you interact with one of the two. I don't know which one it was. All right. Those two animals are between 4 and 6 years old, somewhere in that neighborhood. Never had a calf. They've never produced a drop of milk. Are they lactating dairy cows? Yes. By definition, a dairy animal that is older than 20 months of age is lactating. And once she hits 20 months of age, she is lactating for the rest of her life. In a dry period or not, lactating. They will never have a calf, they will never produce a drop of milk, but they are defined by the FDA as lactating dairy cows. So these restrictions apply. Now, keep in mind that the withdrawal times that are set for drugs in food-producing animals are only valid if I use them according to label directions. If I deviate from that label, everything goes out the window. Those assumptions may not be proper. If I use a higher dose, it increases tissue residence time and it prolongs the half-life. The labeled dose of procaine penicillin G in cattle is 1 mil per 100 pounds of body weight. At best, that is subtherapeutic. So the dose that we commonly recommend is 3 to 5 mils per 100 pounds of body weight. The label withdrawal on procaine penicillin G is 10 days from slaughter. But if I went to 3 mils per 100 pounds of body weight, does 10 days still hold true? No. It would go out to about 28. Okay? If I use it in a species that's not on the label, if I use Nuflor in a cow at 20 to 40 mg per kg, IM or sub-Q, the withdrawal is going to be 28 to 38 days, depending on the route that I give it. If I use it in a goat, it's 60 to 70. If I use it by an extra label route, if I give Banamine IV, the withdrawal is 4 days, single dose. If I give Banamine IM, it's 30, Banamine sub-Q, 60. That's a significant change. And Banamine is a drug of regulatory concern for the FDA. They look for it. All right. Now, performance horses are really no different. We're not going to consume them, but the potential for us to put things into their body that may change the way that they perform, all right? So, for most antimicrobials, there's a 48-hour stand-down time. They're treated, 48 hours later, they can perform. It should be safe from any residue they consider to be volatile. The major exception to that is procaine Pen-G, and there's a 14-day stand-down time or withdrawal. And the reason for that is the procaine moiety on procaine penicillin G has local anesthetic effects. And there's the potential for that to alter the way that animal performs and moves because it may numb pain, okay? And the longer residence time of procaine relative to penicillin means that they extend that from that 48-hour to 14 days to adjust for those things. So keep in mind, just because it's a horse and it's not eaten in this country, there are still issues we've got to think about from the standpoint of performance. Let's keep that stuff in mind. All right. Next, what is the cost? And there's economic costs, but there's also resistance and health that we've got to think about. This is looking at the economic costs. This is a study where they compared tulathromycin to tilmycin to nothing for mass medicating feedlot heifers considered to be at high risk of disease. Okay? One thing that you're going to notice is that at the end of the day, the animals that were given Draxxin at the time of arrival, 2% got sick compared to 6% that were given tilmycin versus 14% that were given nothing. So when you look at this, you say, oh wow, giving them something makes a difference. And if I had a choice just based on efficacy, which one would you pick? Which one would you pick? You know, tulathromycin. I mean, it's about 3 times as effective as tilmycin. No brainer. I'm going to pick that one. But when you look at the economic outcomes, because Draxxin is about $10 a head more expensive than Micotil, at the end of the day, when you look at residual value per steer, it comes up to be a wash. That's the economic cost of it. Even though it's more effective, the upfront cost of it makes Micotil a very reasonable alternative because it's the same on the back end. I can accept that higher risk of morbidity because the upfront cost is so much more. Now, when we look at the resistance cost, this is some work that we did several years ago. These are Mannheimia isolates taken from the same calf 2 weeks apart. The first time we collected those samples, you notice a whole lot of S's next to those drugs, right? In this calf, I could use almost anything. I gave this calf a single dose of tulathromycin, and I come back 14 days later, I pull the sample from it. A whole lot of R's. The only class that I've maintained susceptibility to are the beta-lactams. I've got resistance to tulathromycin, tetracycline, gomithomycin, fluorophenocal, and rofloxacin. 1 dose of tulathromycin precipitated resistance to all of these other drugs. So what's the cost of that? Am I willing to accept it? This is looking at the change in antimicrobial susceptibility from blood cultures of foals. They were taken at admission and then again 48 hours later. What you notice is that at the time of admission, about 70% of the isolates are susceptible to amikacin, 70% ampicillin, 91 ceftiofur. When you look at combinations, ampicillin, amikacin, 94%, ceftiofur, amikacin, 94%. Pretty susceptible. But when I come back over here and I look 48 hours later, ampicillin, amikacin, 57%. I've gone from 94 to 57 in a 48-hour time frame. When I look at ampicillin, 70% to 29%. It's falling quite dramatically. The point behind showing you that is that if I don't pick the right drug first, from an efficacy standpoint, this is what I've got to deal with on the back end. It's going to be hard to deal with some of these pathogens. Really, really hard. So instead of choosing a drug like gentamicin or penicillin, which by itself has little value in these foals, together in combination could give me 94% coverage and potentially leave me with less concern on the back end of that. Efficacy is important when it comes to treatment outcome. And then next, considerations related to human health. Is something that I do to a food-producing animal potentially going to spill over into people? Campylobacter is a huge issue in sheep and goats. And what we know about Campylobacter is ciprofloxacin resistance is on the rise. Between 1997 and 2011, it more than doubled in prevalence. Remember I said earlier, the extra-label use of fluoroquinolones in food animals is illegal. Sheep and goats are not on the Baytril label. Can't use it in them. So why would cipro resistance be an issue when we don't use that drug? Well, feeding chlorotetracycline allows for the emergence of clones of Campylobacter, clone ST8, that not only is resistant to tetracycline, but it also carries with it fluoroquinolone resistance determinants. So even something that we think may be completely unrelated, the way resistance genes are packaged today, they come together as a big family. So our patterns of use in sheep and goats, unrelated to fluoroquinolone use, precipitate resistance in medically important human pathogens. It's something we've got to think about. Lastly is duration of therapy. All right. I would imagine that most of you guys have been taught that when the doctor prescribes you a course of antimicrobials, 14 days, whatever it may be, you take that entire course, right? And longer courses of antimicrobials are probably better. No. This is some work that have come from people with community-acquired pneumonia. And this is as close as I can get to respiratory disease in cattle. They looked at amoxicillin, gemifloxacin, ceftriaxone, and ceffuroxime. And they looked at amoxicillin, 3 days of therapy versus 8 days of therapy. In the group that was given 3 days of therapy, clinical cure was 80%, 8 days of therapy, 80%. Gemifloxacin, 5 days versus 7 days, 80% versus 80%. Ceftriaxone, 5 days versus 10 days, 82 versus 82. Ceffuroxime, which is second generation cephalosporin, 89 versus 91. In some of these instances, we're cutting duration of therapy down by 3 to 5 days. And we're not having any negative impact on the outcome of therapy at all. And I don't know what the right answer is. If I have cattle with septic arthritis, which I see a fair number of, I treat them for a month. It takes that long to get them to resolve. So some require longer durations of therapy. But if I've got a patient that's better by day 3, why do I need to go the additional 11 days arbitrarily? There's no rationale for that. We're going to talk more about that in just a second. In cattle, the best thing we've got is post-treatment intervals. In other words, I treat an animal, and I put a moratorium on retreating the animal for a certain period of time, okay? And so this is the post-treatment interval study looking at 7, 10, or 14-day PTIs in cattle diagnosed with BRD and given Draxxin. So what we're saying is, I diagnose BRD, I give them a single dose of Draxxin, and I wait 7, 10, or 14 days before doing anything else. No matter how bad it gets, I commit to those durations. And what you notice is treatment success, 86 in the 7-day, 85 in the 10-day, 89 in the 14-day. Statistically, they're not different. But with Draxxin, theoretically, I could wait up to 14 days and have no negative impact on the outcome of that case. This is Micotil or tilmycin. Same thing, diagnosed with BRD, I give them tilmycin and I wait 3, 5, or 7 days before declaring them a treatment failure. In the 3-day group, first treatment success, 68%, 5-day group, 73%, 7-day group, 87%. By doing nothing for an additional 4 days, 20% more animals get better. Interesting, right? So the point behind saying that is, and it's not directly correlated to duration of therapy, what it is it's saying I can reduce the number of antimicrobial exposures one animal gets by giving them time to recover. Sometimes the immune system needs to do its job. If after 7 days they aren't better, fair enough. We can treat. The immune system has had its time. The drug has had its time to act as a crutch and make a difference. But they need time to respond. It is unreasonable to expect them to be better in 24 hours. Completely unreasonable. None of us are better in 24 hours when we get sick for some reason. They need time to recover. Okay. So questions about that? Yes, ma'am.
In these studies, did they look at like the 20% that were still left not getting treated? Did they have worse outcomes?
So the question is, in the 20% or so that did not recover with these, no, there's no worse outcomes in that population either. They have an increased number of second treatments, but mortality risk otherwise, and you look down here, treatment failures, relapses, second relapses, more second treatments, but death-wise, same here, there's no difference. So it doesn't negatively, if they're not going to recover, they're not going to recover. And in my experience working with it, there's a reason they're not responding, and it's not because you picked the wrong drug generally. There are other factors that relate to it. Viruses play a role, chronic disease processes play a role, that kind of thing. Any other questions? Okay. So, you want to know, what is the best antimicrobial? What do I treat the dog with a skin infection with? What do I give the horse with respiratory disease, the foal with rhodococcus? Well, one, it's legal in a specific patient. The other thing, you have some reasonable expectation of efficacy. How do you know that? Well, your clinical experience can tell you a lot. In my clinical experience, oxytetracycline doesn't work for very much. So I don't use it very much. I use it for very little, in fact. It is not my first line. Despite the fact that it's legal, I don't think it works. So I put it to the back burner, okay? It's safe for use in a particular patient. free from side effects that I think are detrimental. It's also safe for the patient, and it's safe for the consumer if it's a food animal. The other thing is, you've got it in your practice, okay? It's really nice if you could stock all these different things in your practice and be able to choose, but you can't. You're gonna see common disease processes. In a small animal practice, it's gonna be urinary tract infections, skin, those types of things. So what works best for that? It can readily be administered. It's within the financial constraints of you, it's within the financial constraints of that owner, and you're familiar with it. You feel good with it. If I had to choose one antimicrobial that I could use and treat most things, fluorophenocal. I can get away with using fluorophenocal for most of the stuff that I work with. If you're in a small animal practice, amoxicillin clavulanic acid is probably going to give you the flexibility to treat a lot of crap. There's no need to stock imipenem to any amount. You don't need it that much. So what it all boils down to is, can I do some good? Can I do some harm? Can I get it in the animal, and what does it cost? Selecting an antimicrobial is a very fluid process. It's something that's going to require regular reevaluation of your thought processes, the disease conditions that you see, to make sure you're making the right decisions, because things change over the course of time. 50 years ago, Oxytet was a great choice for BRD. It was a great choice for pink eye. Today, it's not. Resistance has emerged, and it just doesn't work as well. So what you're going to do as a practitioner is you're going to develop a therapeutic regimen using your clinical experience and expertise, also with the best evidence that you have, the best interest of the patients, also balancing the best interests of that client. I mean, realistically, for dogs with skin infections, cephalexin is better than cefpodoxime is on any day. Spectrum-wise, it's a better choice. But why do we choose cefpodoxime, or why do we choose cefavecin or Convenia? Because putting those big-ass capsules into a dog is a pain in the ass. I can give it a single dose of Convenia and boom, I'm done, especially that fractious cat. I hate cats, they scare me. And I work with rodeo bulls. Cats frighten me. But again, even though cephalexin may be the better choice when you think about all this other stuff, because I can get Convenia into that cat and boom, I'm done, that's the best choice for the patient and that client, because I can make it happen, okay? So, you pick the right drug, the right dose, right route, right duration, and the right frequency, everything else being held the same using all of that data. Now, myths, and we'll finish up real quick. All right. There's a myth to say that we invented antimicrobials for clinical use in the 20th century. Alexander Fleming invented penicillin. That's not true. Sulfas were actually the first drug introduced to clinical use in 1931, even before penicillin was. Penicillin was discovered by Fleming, but the sulfas were introduced, actually derived from dyes produced by Bayer Corporation in the 1930s. But we know that antimicrobials and the associated resistance mechanisms have been in existence for in excess of 2.5 billion years. They are natural to the bacterial population. They served other functions prior to being antimicrobials. Signaling molecules, for example, they probably played a role. So the point behind saying that is, resistance is inevitable. They've evolved with this. They've evolved with these drugs. We didn't create it. We've exaggerated it. We've made it worse. We didn't create the problem. Only inappropriate use selects for resistant bacteria. All use selects for resistant bacteria. So like I said before, the most important question you can ask yourself is, yes or no, do they need it or not? That is the most effective way to reduce that risk. So what we're trying to do is eliminate or minimize inappropriate use and try to get to patterns of more appropriate use. It's a hard place to get to. We can work with time and do that. Because the benefits of antimicrobials to society outweighs the collective harm. They have revolutionized medicine. Absolutely revolutionized it. But when we've got the ability, perioperative antimicrobials with surgery, for example, if I can scrub the skin, minimize tissue trauma, have a controlled environment, why do I need an antimicrobial? That's a crutch for poor technique. So those are the things we need to think about. Like we said before, there's a myth that we must complete the full course. Okay? There is no data to suggest longer courses of antimicrobials reduce the emergence of resistance. None. There are certain conditions in which longer courses seem to be more beneficial. Septic arthritis, if you look in people that have ventilator-associated pneumonia, Pseudomonas particularly, longer courses are more beneficial. But most of the time, shorter courses have the same benefit. And the other thing is, shorter courses are actually less likely to select for resistance. And most clinical trials in people have found that shorter courses are just as effective. So, resistance emerges because of new mutations. That's not true. We don't create resistance when we give an antimicrobial. We select for it. Those clones of resistant bacteria probably already exist at a low level in the patient's body. And just because we've resolved that infection doesn't mean that they're all gone. Somewhere in that patient lurks a resistant organism that could cause a future infection. So we've got to make sure that, again, we're doing our best to understand that it's inevitable. What can we do to minimize that risk? And then lastly, we've been taught these terms cytal and static. Cytal kills, static suppresses growth. That has no value to you as a practitioner, none. Makes no difference. What matters the most is efficacy. What's going to work best in my hands? Cytal or static should not factor into your decision-making process at all, okay? No matter what you're taught, they should not. In most of the studies where they found that cytal drugs were beneficial, when they've gone back and looked at the dose they were using, the dose they were using was clinically inappropriate. It was too low to be effective for some of those static drugs. And more studies, in fact, show a benefit to static drugs as opposed to cytal drugs. The point behind that is saying, take cytal and static out of your vocabulary, pick a drug that works in your hands. Whether it's cytal or static, doesn't matter, you know that it works. So you choose a drug that's most effective with a bacterial pathogen in a specific clinical condition. That's the most important part of that. So, with that, any questions about that stuff? Anything? Okay. All right, I'm done. Any questions pop up, let me know. Otherwise, enjoy the rest of your